So I would like to introduce Dr. Grace Fua. Grace is a general practitioner. She works at the Metropolitan Communicable Disease Control Directorate, and she's on the team of the syphilis outbreak. So welcome, Grace.
Thank you very much, Veronica, for this opportunity to share with all of you. As Veronica said, I can't quite see all of you, and I don't have a very good overview of who might be attending. So if I say anything that you don't understand, you want clarification, please do ask questions. So I am here from the Metropolitan Communicable Disease Control. Who are we anyway? We are kind of metropolitan based, so we're not a full public health unit, but we are a public health team based in the metropolitan area. We are in charge of looking at communicable diseases in the metropolitan area and in supporting clinicians and the public in managing those communicable diseases. So we are a bunch of public health physicians, nurses. I'm a GP, and we're always happy to answer questions about communicable diseases, contact tracing, immunisations, if you're in the metropolitan area. So the probably most common reaction that I get when I tell people that there is a syphilis outbreak is, syphilis, isn't that a really old disease? Why on earth are we talking about syphilis in the current day and age? And you're very right, syphilis has been around for a very long time. This is a picture of, well, they believe it's Christopher Columbus. And people have been asking from, the 14th century, where did syphilis come from? Some people say that Christopher Columbus brought it to America when he, took a ship over there to discover the new land. And other people say that Christopher Columbus brought it back to Spain because there was a stowaway on the ship who had syphilis. So it's, a very contentious issue. Why is syphilis around, and where has it come from? From a kind of global perspective, we do know that there has been increases in syphilis in developed countries from the turn of the century. So there has been increasing cases in the UK, in Canada, in New Zealand. It came into Australia, started spreading in Australia around 2011 in Queensland, and came to WA around 2016. And then around 2018, we started seeing it coming down into Perth. So you can see on this graph, that prior to 2005, we had next to no cases in Perth, and then that slow rise, and from about 2016, a steeper rise and then a real takeoff. And to begin with, the rates of infection were really rising in men who have sex with men, and quite held to that population. But unfortunately, from about 2018 onwards, we started seeing it creep into other vulnerable populations. So people experiencing homelessness, Aboriginal people who might use methamphetamine or other drugs of abuse. And then we started seeing it get into women, and of course, women fall pregnant. So we started seeing cases of congenital syphilis, of babies being born or dying because of syphilis transmitted through mum during pregnancy. Another graph just showing the same thing that, I've been saying, that real increase. And the promising thing, so that last dark teal bar represents 2021. So the slightly promising thing is that you can see that in our homeless population and in our Indigenous population, those numbers start to stabilise in 2021, but you can see that in our women of reproductive age, those numbers are just continuing to go up. So what do people know about syphilis? What kind of symptoms do they associate with syphilis? And I'm just going to go through it briefly now. Primary syphilis is the first stage in syphilis, and we break syphilis infection up into several stages, even if those stages might not be very clear. Scientifically, we can break it up into several stages. And the first stage starts about 3 or 4 weeks after you might be unlucky enough to be infected. So that little spirochete there, that's our little syphilis bug, and it burrows into the skin where you've had contact with someone who's had syphilis. And typically that is mucosal skin, so oral skin, vaginal and anal skin. And what then forms at the site of infection is an ulcer. Typically, we call that a syphilitic chancre, and the textbook chancre is a single indurated painless ulcer. That's your kind of typical syphilitic ulcer. But syphilis, as many of you might have heard, is known as the great imitator. There's the textbook presentation, and then there's all the other ways that it likes to present to just completely befuddle us. So it can definitely be painful, it can definitely be multiple, and it has definitely been mistaken for herpes, for herpes 1 or 2. So the other interesting thing about the syphilitic chancre is that whether you treat it or not, it goes away. And I've heard some clinicians say, oh, you know, I often say to people, if it doesn't go away, come back and then we'll look at it. And my attitude to them is that's probably then going to miss an opportunity, because if they go away, the ulcer will go away and they will miss the opportunity to be tested and treated for syphilis. So if you see an ulcer and you are a clinician, or you're talking to someone who you can give advice to, the best thing would be to swab it so that they can test it for syphilis. Now, we talked about how the syphilitic ulcer can go away, and if it's not treated, then they can slip into a secondary phase 2, 3, 4 months after initial infection. The secondary phase is a much more kind of all over, can be a wide range of symptoms type of phase. And they can have a flu-like illness, so fevers, aching muscles, swollen lymph nodes, again, very vague. They apparently up to 90% of people will get a rash. The textbook rash is on the palms of the hands and the soles of the feet, but it can definitely mimic all sorts of other rashes, looking on the trunk, looking a little bit measly, the kind of maculopapular rash. But again, without treatment, it can go away by itself. So, it can get put down as all sorts of other things. Oh, maybe I ate something funny, or I touched something funny and now it's gone away. I don't need to worry about it, which is another kind of pitfall that people might fall into. It can cause some patchy hair loss. It can cause these kind of grey, moist patches in the warm, moist areas of the body, like in your armpits, in your groin, and those can also be if you see one of these, they can also be swabbed for syphilis. And it can actually cause neurological symptoms. So people can have eye problems, they can get sudden onset deafness, they can have cranial nerve palsies. So, a part of their eyes is not kind of moving properly. So there's quite a wide range of different ways that it can affect the nerves of the body. Now, this is a busy graph. I'm just going to talk you through it. You can see the first 2 little humps, that's your primary phase, and that's your secondary phase. If the syphilis gets missed and the patient is not treated, then after the secondary phase, the symptoms can all subside and they can go into a latent phase in which they have no symptoms. In the first 2 years of being infected, however, they're still very infectious to anyone that they might have sex with. And women who are pregnant are also very infectious to their babies. So you can see that there's a section there where they have no symptoms, but they're still really infectious. So this is one of the dangers of syphilis. If they remain completely untreated, eventually that level of infectivity falls off and they just go into a latent stage of disease where they don't have any symptoms and they're not very infectious at all. But about 1/3 of these people later in life can develop really, really serious complications, cardiovascular complications, dementia and psychiatric complications, and that's where it can cause death. So that's also why it's important to treat syphilis. So tertiary syphilis, as I mentioned, is that end spectrum where a third of people who are left untreated develop these really serious complications. But thankfully at the moment in Australia, that's rare. We're not really seeing very much of that at all. Now, congenital syphilis, as I mentioned earlier, is when syphilis is passed from mum to bub. And we know that almost all bubs born to mums with infectious syphilis will actually be infected. It can cause devastating ramifications such as miscarriage, fetal death in utero, death shortly after being born. The babies can be premature, they can be very small, they can have a lot of problems with bony deformities, severe hematological problems, severe neurological problems. So you can see that these are quite devastating consequences, especially for an illness that we can treat. So congenital syphilis is altogether preventable, and that's what we're trying to do. So how do we test for syphilis? There are two main ways in which we test for syphilis, and both those tests are really good at picking it up. The first is through serology, through taking blood. And for those of you here who are involved in interpreting results, I'll just go through it briefly. The lab will first do a test looking for antibodies. And if that's negative, then they don't do any more testing. If there's no antibodies, then the patient does not have syphilis. If they have antibodies, however, that could represent current disease or it could represent old disease, because once you've had syphilis, your bodies will always have syphilis antibodies. So even if they've been treated in the past, their antibodies will still come up positive when they get tested in the future. So if they come up positive for antibodies, then the lab will do another test looking for disease activity. This is not specific to syphilis, it's looking for general disease activity, and other diseases can make it active as well. But generally speaking, if you have positive syphilis antibodies and high marker of disease activity, so you have a high RPR, then you're likely to have infectious syphilis and you need treatment. The other way of testing for syphilis, as I mentioned before, was swabbing ulcers or condylomata lata, and they can be sent for syphilis PCR. And the results of this are much more straightforward. If they're positive, then we know for sure that that is syphilis and the patient needs treatment. So because syphilis has now, the rates have now increased dramatically, the Chief Health Officer did declare a syphilis outbreak in metropolitan Perth in 2020, which was, as you might remember, the same year as the other very significant outbreak was declared. And because of that declaration, we have changed our recommendations for who gets tested. So firstly, we ask everyone to be aware that syphilis is a current issue, that it's not an old disease. And so if they're seeing someone with a rash, someone who's unwell, to think that syphilis could be a possibility. The second thing that we're asking people to do is to include syphilis testing when they screen STIs. Now, many people will get a blood test when they get an STI screen, but there are some people who will be like, oh, I don't think I'm really at risk of HIV, and I'm immunised against hepatitis B, and there's no syphilis around anyway. I don't need a blood test. I only need a urine or a swab test for chlamydia and gonorrhea. But again, now that the setting has changed, we're asking people to get a blood test for syphilis when they're getting any STI testing. The third thing is to swab any funny ulcers that you can't explain straight away for syphilis PCR. And a lot of people aren't aware that you can swab for syphilis PCR because usually people swab to test for herpes or to test for chickenpox. And the last thing is that pregnant women used to only be tested for syphilis when they first went to the doctor. When you first go to the doctor, you get a whole range of blood and urine tests, testing for a whole heap of different things. But now we're asking for that syphilis serology to be repeated again at 28 weeks, often when women get their diabetes test, and again at 36 weeks. Now, if any of you are from the regions, then in our Goldfields, Pilbara, Kimberley regions, women are also screened at delivery and at 6 weeks postpartum. Okay, so the good news story, after giving you all the bad news about syphilis and congenital syphilis, is that syphilis is readily treated and the treatment is readily available. So, syphilis is this really old bug. It's not that sophisticated. It doesn't mutate like the coronavirus does. It kind of stays the same, and it almost always gets treated by penicillin. The kind of treatment failures are very, very rare. But the type of penicillin that we use is this is what it looks like. It's long-acting intramuscular benzathine benzyl penicillin. So it's not oral penicillin. It's given by injection, and one dose is 2 of these injections. Now, the injections themselves are not very nice to give. They're quite uncomfortable, and so if there's 2 practitioners available, then one person giving 1 syringe into each buttock would be preferable for the patient's comfort. If they're in that first 2 years of infection, so infectious syphilis, they just need that 1 dose and that treats them. Important for the patient to know that after they get treated, they can actually feel quite unwell. So they can actually get fevers, and they can, get the shakes and feel dizzy. And that's basically the bacteria being killed off by the penicillin and the body kind of reacting to that. It's not a dangerous reaction, so you can just let them know that if they have some Panadol, some Nurofen, some rest, lots of fluids, that it will go away. But it's important that patients know that, otherwise they feel like you've given them something that is going to kill them. When they get treated, if they're a woman of childbearing age, we would really like to double check, triple check, quadruple check that they aren't pregnant. So a pregnancy test would be really good, and another blood test just on the day that they get treated, so that we can compare their follow-up results with those blood tests to make sure that their treatment has been successful. They shouldn't have sex for 7 days, because obviously you don't want them being treated and then being reinfected again. And if you don't know how long they've had syphilis for, perhaps their last syphilis test was 5 years ago, and maybe they have had syphilis for more than 2 years, then they should have 3 doses over 3 weeks. It can be tricky to know how much treatment to give them, and this is where you can seek help from sexual health clinics or from us. We often have records of older infections. We can confirm whether someone has been treated before, and maybe this time they don't need to be treated again, or they only need 1 dose, or whatnot. Now, the other really key element of management is contact tracing, because as I mentioned, you just don't want these people to be reinfected again. And remembering that people define sex in all sorts of different ways, so being sure that you capture all forms of sexual contact that they may have had. Tracing back can be quite tricky, because if they've had the infection for quite a long time, you might need to trace back quite far. But again, this is where public health can step in and help with that. And you come up with an agreement with the patient, basically, about who's going to contact them. Sometimes it's quite straightforward. The case knows who might have given it to them. They're willing to give them a call themselves, or to let them know anonymously. But generally speaking, if it gets complicated, then public health units can step in. If you have someone coming in who says to you, oh, someone that I hooked up with a couple of weeks ago has just let me know that they've been diagnosed with syphilis, then it is appropriate for them to be tested on that day before their results come back. So take their blood, but then you can treat them there and then before they leave. And the benzathine penicillin can be ordered from the doctor's bags, so they can be kept on site at practices at all times. You don't need to send people out looking for scripts, because pharmacies often don't stock the benzathine penicillin anyway. A little bit more just about follow-up for anyone who's a clinician out there. They do need to be followed up at 3, 6 and 12 months for repeat serology, and those are also good opportunities to do reinfection screening, to see whether or not they need any other STI testing. I didn't mention earlier that anyone with a positive syphilis diagnosis needs to have the full STI testing done as well, and following them up can be a good opportunity to see whether or not they need that done again as well. So now you know that there's a syphilis outbreak. You can let others know. You can think about syphilis if you are coming across any curly kind of rashes or situations. You can advocate for pregnant women to be screened more regularly, or explain to women why this is needed. You can make sure that any funny looking ulcers are sent off for swabbing. You can make sure that any practices you're associated with have benzoline penicillin stocked in the fridge. And if you want any further information or any further training, then these are some good resources. And that's the end for me.
Thanks very much, Grace. That was a really good overall look at syphilis. Thank you. I actually picked up quite a few things from that. That was awesome. So I have a question from Erica Shaw. She's at WAC. Are the stats at the beginning for the metro area? Oh, yes. So they were metro area stats, Grace?
Yep. They were metro area stats because I work in Metro CDC. ASHM they do spotlights on syphilis or syphilis updates on a regular basis for WA, and we usually use statewide and national data when we present those.
Okay, and the other one was, does infectious syphilis refer to syphilis in the body up to 2 years?
Exactly right. Syphilis in the body up to 2 years is considered infectious. After 2 years, they stop being infectious sexually, and there's a decreased risk of transmission to the baby in pregnancy, but there is still a risk. So we want to make sure that pregnant women and women of childbearing age are fully treated to completely negate that risk altogether.
Mm-hmm. Mm-hmm. And the other question, was it possible to get a copy of your slides?
I think so. Should I distribute that through you, Veronica?
You can do that through me. That's absolutely fine. I can send out to the group. Yes. Yeah. Yeah, that's great. And also wanted to say that was amazing, Grace. Thank you.
Thank you. That's very kind.
It was very informative, Grace, and I really like these workshops because I gain more information about different STIs, and today's one I really enjoyed it and gave me a few ideas and stuff too as well. Thank you.
Fantastic. I'm glad to hear that.
So that was Tracy, and she calls in from Derby, the Aboriginal Health Service in Derby.
And I feel like because syphilis is so complicated, when I first started in it, every time I heard something about syphilis, I'd learn something new.
Yeah.
So I think that's what it would be like for you guys, because there's so many layers to it.
Absolutely.
That's right. And sometimes different presenters, talk about different things. I think it's really good. Yeah. Charles, you have your hand up. This is Charles Douglas from the Goldfields.
Yeah, thanks. That was absolutely amazing. Excellent presentation. And I'm going to be really picky here now.
Oh, no.
And I apologize for that. But you said the oral, vaginal and anal, you forgot the penis. And I think we have to remember that because you said mucous membranes, but you can get the chancre on the penis as well.
And you're absolutely right in my keenness to make sure people didn't forget the other sites. I left off one of the most common sites. Big oversight on my part. Thank you, Charles.
Okay. Was there any other questions from people?
Yeah, Veronica and Grace, I just ask, just with treating people, it's a lot for them to take in, and I've had quite a few positive cases up recently. Can you recommend any information advice sheets that we can give to people? Like I've got obviously your plain syphilis one, but just more referring to the treatment and the follow up from there.
You mean patient for patients?
Yeah, patient advice. Yes. Yeah.
That's a good question. Have I seen good patient information about syphilis treatment? I'd have to look that up and come back to you.
Okay, thank you. Yeah, it's just a lot for them to take in, you know, at that time. Yeah. Especially because we're doing a whole health check usually at the time. Yeah. Yeah.
So Sarah is actually calling in from Roebourne. So she works at Mawankara Health Service. And Sarah, there was a hold up with our syphilis flip charts at the printers, but they've assured us that we're getting them. So they're all sitting there, like hopefully we'll be getting them out to our services, and that may help because you can actually use certain parts of the flip chart to have discussions. Okay. So that might be helpful for you as well.
Perfect. Lovely. Thanks.
Oh, and Tim Cook from OVARS has just given us Young Deadly Free have some good information sheets. So you can go onto the Young Deadly Free website and they actually have a huge amount of resources. A lot of them are videos, but there's some good written resources as well. Erica Shaw has just sent me the M Clinic. There's a resource there. So I'll gather these resources after this session and I'll put them all together and send them out to the group if you like, and include you as well, Grace.
Thank you.
Yeah. And they have a resource that patients can give and can give to their GP as well to help with the discussion. So that's great. All right, I'll have a look at those as well and send them out. Okay. Well, it's almost 12:30. Unless anybody else has got questions. You're getting a lot of thank yous, Grace. It was fantastic.
Thank you very much for having me, Veronica.
Yeah, so thanks very much, Grace. And I will forward Grace's presentation with those resources out to everyone. Enjoy the rest of your week. See you.